Okay, so we're going to have our second presentation now. Everybody's settling in. Okay, so I'm going to introduce to you Constant Mouton. And Dr. Constant Mouton is a registered psychiatrist and certified ARISE interventionist, currently living and working in the Netherlands. He holds a fellowship at the Colleges of Psychiatry of South Africa and a Dutch registration as a psychiatrist at the KNMG, and he is medical director at Triora Recovery Centers in Netherlands and Spain. He's also the director of ARISE Consulting Europe. Dr. Mouton trained as a medical doctor and neuropsychiatrist in South Africa, where he gained valuable experience in working cross-culturally. This unique skill enables him to respect and utilize people's cultural heritage, as well as religious and spiritual beliefs, all geared towards understanding a person within their own context. Having lived and worked abroad, he has a personal understanding of the challenges faced with living in a different country than you were born in. As a trained medical specialist, he values the biopsychosocial model of psychiatry. In addition, through his studies and own experiences, he utilizes mental health and addiction problems holistically and prefers to utilize a biopsychosocial, cultural, spiritual context when working with clients and their families. And he's going to talk to us today, and the title of the presentation, When You Can't Keep Your Eye on the Ball, ADHD, Addiction, and Not Losing Sight of the Bigger Picture. Thank you.
Thank you very much. Thank you very much. Is my sound good? Can everybody hear me at the back? Here is good? Sorry? Too soft? Can we put it up a little bit? So I can move this. Is this better? Let's test that. Is that better at the back now? Still not? I'm not sure if I can do anything. Shall I just... Let's see if that's better. That sounds much better. Great, because I have a soft voice as well. Judith is also from South Africa, and she always says we have the soft South African voices. So if you can't hear me at the back at some stage, just put up your hand and... or we'll blame Judith. No, we don't blame. Thank you very much for the invitation. It's wonderful to be here. Thank you to the Gruben Foundation, to the people from ICAD for inviting us here today, and for you for hosting us. It's really great to be here. I had a lot of discussions about this first slide, whether it was firstly appropriate to put something like this on as the first slide or not. And then we ended up having discussions, is she keeping the balls on her eyes really to block her own view because she's hyper-focused, or is she not seeing the big picture? I'm going to leave it all up to you. There's nothing behind it. What is interesting is also I showed it to, I think, Christoph, and Christoph said, well, it's great because you don't have a 5-year-old red-headed boy running around the show as the typical person with ADHD. You have an Asian female adult. So maybe that's even more appropriate. I would like to start with some definitions. We're not going to go into too many definitions. I was very happy to see at the Cape Cod Symposium that people in the States generally use this term, co-occurring disorders. In Europe, we still talk about dual disorders, dual pathology. And actually, you guys are right. Co-occurring disorders is the right term to use. The reason is dual disorders was a concept looking at addiction plus mental health issues, and that was kind of it. And nowadays we understand much more about it. We understand that there's also medical things happening, things in your body, social, family, financial issues, you name it. It's really a much bigger concept than just the two disorders. So what I'll be talking about today is ADHD as an example of a co-occurring disorder, and I'll go a little bit back and forth between general concepts of co-occurring disorders, and with a big focus on ADHD, especially in adults. Where I work, we treat about 40% of our patients in the inpatient facility has undiagnosed ADHD, some diagnosed. So from that perspective. So to start off with some numbers, and I'm going to try not to bore you to death with too many numbers, because it could get very boring. In the Netherlands, we had a big study called the Nemesis trial, done in 2010, and that looked at the lifetime prevalence of certain things. So I picked out a few for you. So in the Netherlands, your chance of being ever diagnosed with a mental illness is 42.7%. Substance-related disorders, 20. Same for mood and anxiety disorders. And ADHD, this is lifetime prevalence of 9.2%. Patients with severe mental illness, if you look at that group, 40 to 60% of them will have a substance use disorder, and 60 to 80% of patients in addiction units have a co-occurring disorder. Can I maybe just see by a show of hands who works in psychiatry mainly? Anybody that works in an ADHD unit, treating only ADHD, only addiction, medical field? Great, okay. So if you work in an addiction unit and you see less than 60 to 80% of patients with something else happening, then you're probably missing it. I went on to find some data from the US, and it's comparable. There's a slightly higher number of any mental illness, I think it was, yeah. Substances were lower, ADHD was kind of similar, anxiety a little bit lower. So let's move on to the prevalence of ADHD. So the worldwide prevalence of ADHD in children is between 3 and 12%. The average is 7.2%. And in the US, you guys are on 11%. So it's a little bit higher than the worldwide average. I don't think it's good or bad. I think, yeah, we'll maybe get there. I think it has to do with a consciousness about the disorder that differs per country. You also see differences in the numbers over years, so who knows who's right. It's also not about that, really. In adults, a lower number, on average 1.2 to 7.3%, with an average of 2.5. Once again, the states are a little bit higher, but that's how it looks in the world. If you look at boys versus girls being diagnosed, I put the slide in for two reasons. The one reason is that you can see that boys are still more diagnosed with ADHD than girls. And the question is if that is correct, if there are really more boys than girls with ADHD. There are many theories that girls are underdiagnosed because they present differently. They are in general more calm, but they might be more inattentive. And they compensate in different ways. Boys are kind of all over the show, and we don't try to hide it even. So you can see it easily. And in girls, it gets underdiagnosed, in my opinion. Second reason for this slide is that you see that there is a gradual upward trend. So we are diagnosing more and more. And once again, not good or bad. I think we are getting more aware of ADHD, and I think we are getting better at diagnosing. The question is everybody equipped to diagnose ADHD? So we're still not sure if it is actual overdiagnosis, and it's different per country as well. If we then look at children and adolescents with co-occurring disorder, with ADHD, and we look at which co-occurring disorders do we see, so the orange bars are children and adolescents with ADHD, and the blue ones are without. We really see incredibly high numbers for oppositional defiant disorder, learning disabilities, conduct disorder, anxiety, and depression. It's not on here, but what should be on here as well is substance use disorders. So it's not from the study. This study was done in 2014, and unfortunately I see a lot of children as well with substance use disorders. If we go to adults, we see a similar pattern of types of disorders. We see mood disorders, and it can be anything from unstable moods gets reported in studies to depression, bipolar mood disorder, a lot of anxiety disorders. We'll get to why that is just now. Personality disorder. In the literature, we see a lot of antisocial personality disorder, and it gets described as, a progression of the conduct disorder. But actually what we see in clinical practice in the Netherlands is a whole spectrum of personality problems. And of course, substance use disorders. What's quite alarming is that 80% of patients will have one co-occurring disorder and 50% will have two or more. So you really see that there is a cluster, and you can't work from the hypothesis of dual disorders. It is really co-occurring disorders. The prevalence of substance use disorders in adults with ADHD is around 28%, and adults with ADHD in a group with substance use disorders, the other way around, is 23%. So wherever you work, whether you work in a substance use or addiction unit or in psychiatry, there should be about 25% of the other. That's just, and that's the last number slide. They can be very boring, but I think they're quite important as well. So the question arises, what comes first, the chicken or the egg? Always the question. And this is with co-occurring disorders in general. So there are four different options. So the first option is a primary mental illness or just illness leading to the addiction, the obvious one. I must say here that I said leading to the disorder. We must also think of unmasking the disorder rather than leading to. The first one, which is alarming, is medicating or self-medicating the psychiatric or mental or physical disorder. So think of anxiety, chronic pain. We medicate these patients, but patients also medicate themselves, and they learn to self-medicate. Medicating or self-medicating, actually, the side effects. An example here would be if you think of patients with schizophrenia. We have drugs to take away the positive symptoms of the schizophrenia, so hearing the voices, take away the delusions. But our medications are terrible with regards to side effects. They make people have what we call extrapyramidal side effects. So people get stiff, they walk difficult, they don't have facial expression, they feel a little bit unaffected. So they smoke because it fixes that. Mental illness itself can trigger or worsen addiction. Think of a patient with bipolar mood disorder that has a manic episode, becomes impulsive, and is at risk for a relapse. A little bit further removed, somebody with panic disorder figures out that alcohol helps. That releases the anxiety, but in the end, the alcohol makes the person less impulsive, and that can lead to another addiction, like gambling addiction or shopping addiction. And I put this in twice, actually, but I think it was subconscious because it's so important that we do prescribe medication that get people addicted. I think there's we touched on the opioid problem, but in Europe we struggle with sleeping medication, for example. Lots and lots of sleeping medication, overprescribed. People are on it for years, and we struggle to get them off. So let's look at this other way around. The primary addiction leading to psychiatric sequelae. Think of intoxication. So if you're intoxicated with something, you might get intoxication delirium. Another one is substances can unmask the underlying mental illness. There's contradicting evidence suggesting whether it is causative or not. There are studies that say that cannabis can induce the first episode of psychosis, but there is also something called substance-induced psychotic disorder. Substances can worsen the existing mental illness. I think we all know that if you're at risk for schizophrenia and you smoke too much weed, then that worsens the psychosis. Third option is that there's absolutely no relation between the two, or the three or the four disorders. This is described, and I must say honestly that if I catch myself getting to this point in my diagnostic endeavor, then I usually blame myself for being a little bit lazy and missing something. But okay. There could be common etiologies. Think of biopsychosocial factors leading to both conditions. And like Christoph said, childhood trauma leading to addiction, but also ADHD leading to addiction. We're going to get to that just a little bit now. There might be shared genetic risk. ADHD, there is a shared genome for ADHD and addiction, but this is very new, so we're not sure about this yet, but there is some evidence of that. So the question arises, why do people start using drugs in any case? I mean, I think Christoph gave a very good lecture on that. I'm a shrink, so I'm going to try and shrink it a little bit, make it a little bit smaller. People start using experimentally in the adolescence phase. We've all been adolescents, we've all tried something, or not. Experimental, like Christoph explained very nicely, that kind of rolls over into adult use and dependence. But very simply put, to feel good, to feel better, or to do better, those are actually the 4 options. And I want you to, I mean, this is not a comprehensive list, but keep that in the back of your mind when you think of co-occurring disorders, and especially ADHD and addiction, of why these people will have a high risk for addiction. So the next thing I want to discuss is what happens if we don't treat ADHD in adults. So failure to treat ADHD in adults is linked with increased risk for unemployment, more sickness, absence from work. It's associated with illicit drug use and alcohol use, lack of academic achievement. It's costly to society. And just go back, these are all level 1 evidence, so it's really valid evidence. They have higher rates of poor social adjustment, higher rates of family and marital conflict. It spreads into the family. And Judith will also get more into family work later on. I will also show you a little bit things about family, but it does spread into the family, the consequences of it. 4 times increase in criminal convictions, so they have problems with the law. And a detrimental effect on the caregivers, relatives, and parents. Once again, it spreads into the family. And this is the part that, I don't know how it is here in Newport, but many places that we consult, we see that it's so focused on just treating the child or the adult and not looking at the family and what happens there, that we forget that ADHD is also a systemic disease that infiltrates the family, the community, and the general function of the person. So as Christoph said as well, addiction is a severe, chronic, and potentially life-threatening disorder. This is what gets me out of bed in the morning. The one doctor said this morning that working in the ER is a bit chaos, but working in addiction care is quite similar. There are possibilities to treat ADHD and addiction, and it is, it's actually very nice to treat these patients because you see results quite quickly, and it makes a huge, huge difference. So if there are possibilities, we should utilize them. You could guess this one, undertreating ADHD increases the risk of relapse of addiction, and vice versa. The addiction is also negative for the outcomes of the ADHD. So all around, clear evidence, I think, that we should treat this comorbidity. So what are we dealing with? Is it really too big to handle for us? This is a great research done by Farron, where they looked at the timeline of ADHD. And the reason I put this in is kind of for us to realize where we are in this battle against ADHD. You can see that we started off way back when, discovering that there are hyperactive children and inattentive children. Adults we never actually thought of, I think. But then here, we see that in the 1980s was the first time that the DSM actually operationalized diagnostic criteria. Before that time, we were thinking of, we used methylphenidate, for example, for behavioral disorders in children. So it was much more wide, and now we're kind of focusing more and more. So in the 90s, we got a little bit more of a refined criteria, DSM-4. And we'll see that in 2000 was the first time, right at the end of the bottom, that non-stimulants were approved. So this is quite significant. If you have a patient in his or her 50s or 60s that were treated as a child with methylphenidate for behavioral behavioral disorders in children, as a big term, the diagnosis might have been wrong, and that might have been the reason for the bad outcomes. But in my clinical practice, I really see a big difference between the 50, 60-year-old patients and the 20-year-olds, who are probably, the 20-year-olds are probably from the atomoxetine phase. We've had non-stimulants to treat as well. The diagnostic criteria were much more refined, and there's a much lower risk of addiction. So just keep that in the back of your mind as well. Looking at the lifespan approach, I'm not from the UK, but I thought this was a fun slide. I am from Holland, so this is also great work. It's done by Steven Stahl, which some of you might know. And this is the, if we look at the lifespan of somebody with ADHD, and what you will see is that in preschool, this thing goes very dark. Usually it's quite cool, but it's now going quite dark. Here you have everything high. So kind of in the school age, you have a high level of impulsivity, hyperactivity, and inattention. And what is low in the light blue line is the comorbidity. So we don't see that much comorbidity. But as we go along, the impulsivity, hyperactivity decreases. This should actually be adjusted because impulsivity only decreases in adolescence, at the end of adolescence. The inattention stays. And that's the thing that we forget in adults, is we still look for the hyperactivity in the adults, whereas you must actually look at the inattention. That's much better. And of course, as you can see in the blue line, the comorbidity really skyrockets at the end. So we'll go through a few of these phases to kind of think together about how does this develop? How do we go from being an undiagnosed child with ADHD to an adult with ADHD, addiction, a mood disorder, self-esteem problems, etc., etc. So, quick question. Does anybody know who this is? Except Judith. Well, the front row knows who it is. Because, anybody knows who this is?
Is it Philip from the German Volkshochschule?
Close. It's Fidgety Philip. Very close, yes. So this is from a poem that was written in 1844 by Heinrich Hoffmann, called Fidgety Philip. And what you can see on this slide is you can see the little boy pulling everything off the table because probably he couldn't sit still. If you read the poem, he couldn't sit still. It was impossible that day. And you look at the parents trying to solve everything, make everything better. So if you read the poem, it's not actually just about this little boy that is very hyperactive. You also read the shame and the blame from the parents. The comments like, why are you so naughty? The finger pointing. Oh, I shouldn't point at you, Christoph, sorry. I pointed at Christoph, sorry, Christoph. The finger pointing, the blaming, the distress of the family is described quite nicely in this. And this was in 1844. And I mean, yeah, since 1844 until quite recently, we haven't been looking at the impact on the families. So if you are, oh wait, there's a second one, another one. Anybody knows this one? I'll be very impressed if you do. I didn't know this until this talk. Which one? That could be right in German, yes. In English it's called The Story of Johnny Head in Air. Same author. Yeah, exactly. Yeah, that makes sense. So, same author, kind of the same year. This is the inattentive type that he described. And Johnny Head in Air ended up falling over things the whole time and being very clumsy. And once again, in this poem, it also is quite a lot about the shame and the blame and how everybody's like, how are you going to survive in the world? Kind of the distress about this child. So keep these two characters in the back of your head throughout the talk, because we're going to look a little bit more at what they experience. So if we look at the presentation of childhood ADHD, the hyperactivity is the typical thing that we see. The small, red-headed boy, kind of like the stigmatized picture that we always see, climbing over things. If you work in child psychiatry, you know how it is to have them in your office, really going everywhere. So they have restlessness, difficulty in remaining seated, fidgeting, running, climbing. There's a lot more. There are many more criteria, but these are the main ones. Impulsivity, blurting out answers, interrupting, talking excessively, acting without thinking of the potential consequences. And then the inattentive side, so Johnny, Head in Air, daydreaming, not listening, not finishing the assignments, working slowly, And you can just imagine how it is if you are a child like this, what you get from your parents and from your teachers and what they tell you. So usually they experience what we call reactive adversity from the parents, teachers, and the peers. So everywhere they go, they hear that they are lazy, they are naughty, they're impossible, we can't cope with you. From the peers don't want to play with them because the peers without ADHD probably get tired of them, but they also get into fights. So everywhere, I mean on all levels, they experience adversity, trauma if you want, from a very, very early age. This obviously leads to self-esteem problems, difficulty socializing, academic problems. And Christopher spoke quite a lot about ACEs, adverse childhood experience. This is a slide on ACEs. You've heard a lot about it this morning from Christoph. So these are the same things. Physical abuse, emotional abuse, sexual abuse, physical and emotional neglect, mental illness in the family, incarcerated relatives, mother treated violently, substance abuse, and divorce. So these are the childhood traumas that they looked at in the ACE studies. Can anybody guess, in a group with ADHD, how this would look like? Which ones would be more in a child with ADHD? Okay, all of them are actually higher in children with ADHD. I'll show you the slide on the study just now. I'm treating a patient now that gave me permission to tell you guys. It's a lady with a child with ADHD, and she came to see me about 4 months ago for the first time, and we're doing therapy now. But she has a child with ADHD that seems untreatable. So she's at a center, a specialized center for ADHD. She gets medication, she gets all sorts of, she has a whole healthcare team around her. But really, in this lady, she presented, so I'm treating the parents of the child. There is mental illness. The mother has a burnout and a severe depression, well, actually a panic disorder. She's been treated violently through her husband. The husband also, through his stress, became very violent. They're divorcing now. And the poor child is really going back and forth between parents at this stage with a lot of neglect, a lot of decrease in emotional availability in any case. So you really see this, you don't see all of it in each and every patient, but it really is quite severe. So like Christoph said before, if you have high numbers of ACEs in childhood, this is what you can expect in adulthood. So lack of physical activity, smoking, alcohol use disorder, drug use, missed work, severe obesity, diabetes, depression, suicide attempts, high risk of STDs, we'll get to that just now in adolescence, heart disease, cancer, stroke, COPD, and broken. So this is kind of the main outcomes of the ACEs study, just a short summary of it. So this is a study I told you guys about with ADHD and ACEs. This is the first published article about this. And the bottom line is that children with ADHD had a higher prevalence of each ACE compared with children without ADHD. So what Christoph also describes about the childhood trauma, you really see that in ADHD. And I think we don't think of ADHD as a traumatizing disorder. We just think from a blaming perspective instead of, well, it is really a trauma. Just looking a little bit at the diagnostic things, it is quite difficult to distinguish between trauma and ADHD. When you are a child psychiatrist, I see Judith nodding in the front row. The overlap is the interesting part. So difficulty in concentrating and learning, you see in both trauma and ADHD. Being easily distracted, not seeming to listen, disorganized, hyperactive, restless, difficulty in sleeping. So you can see it's really quite complex. I'm not going to go through all of this, you can get the slides. But it is quite complex, which gets me to where we're going at later, is the diagnostic process. So this is an example of how complex it can be. So the diagnostic process really has to be in depth for these patients. So as I said before, the co-occurring disorders in Fidgety Philip and Johnny Head in Air would probably be oppositional defiant syndrome, which is actually just not listening, conduct disorder, learning disabilities, anxiety, depression, and unfortunately addiction we see nowadays in children. If we move on to adolescence, really quite similar to childhood. The thing is that the hyperactivity is a little bit less, but the impulsivity might even be a little bit higher, as in most adolescents. It's described as the transitional stage between childhood and adulthood. Working with transitional family therapy, I thought this was quite an interesting term. This is a huge transition, and it is difficult even if you don't have ADHD. So for guys with ADHD, it's even more difficult. The consequences are quite similar to those of children, where the difference gets in is experimenting with drugs and sexual risk-taking. These children are really, really at higher risk for sexually transmitted diseases and quite serious things from that. More acting out behavior. Let's get to adulthood. So, who knows an adult with ADHD? There we go. Christoph. Okay, so I want to start with the strengths of people with adults with ADHD, things that we commonly see. We see great creative minds. We see enthusiastic people taking on a lot of tasks, maybe even too much. Intelligent people, hard-working people, people with good humor, quick in execution of tasks. I mean, bosses love these people because they get things done up to a certain point, unfortunately, and that's where the problems come in. So it's not all doom and gloom. I must be honest, I love working with people with ADHD. Because of some of these reasons. They really are great people. So, but the problems come in with the symptoms. So the inattention is the main symptom. Think of procrastinating. So they might get it done, but they procrastinate as well. Being late for things, forgetful, disorganized, making careless mistakes. Hyperfocus is an interesting one. I always get the question, okay, inattention and hyperfocus, how does that go together? So if you think of ADHD, Stephen Stahl describes it quite nicely. He describes that if this is your attention span and you have impulses coming through the paper, if you have a normal attention span, one thing will go through and your attention will be able to block the rest. In ADHD, everything comes through, so it's exhausting. And what you get with hyperfocus is, and this is linked to computer gaming addiction, for example, is you focus so much on one thing that you kind of get blocked off from the rest. And that's what we mean with the hyperfocus. So it's almost an adaptive mechanism to all these impulses coming through. And that can be anything. It can be computer gaming, it can be work, it can be gambling, whatever. A lot of online things are linked to this. Impulsivity, frequently quitting jobs, not great for your CV. Starting but not finishing multiple projects, so having a lot on your plate, not finishing it. Promiscuity, impulsive spending, outbursts of anger, interrupting others, also not great for your social life. Hyperactivity looks a little bit different than in childhood. So here we see people who have difficulty in relaxing, still being restless, excessive talking, difficulty in waiting in line, and engaging in excessive sporting activities. We have a lot of these patients coming in, and it really is a subgroup of patients that we see in our clinic. I think it's just coincidental, or through marketing. I don't know why we attract this group, but we ended up making a specific group for them. It's young male, young adults, around 25 years old, with ADHD, usually a mix between alcohol and cocaine use. And they are really big guys, like big muscles and tattoos, and they come in with their protein shakes and the things as well. And we see a lot of this group of patients for some reason. So what happens if you have this in adulthood? You underachieve in everything. It can be academically, it can be in work, it can be in your relationships, but underachievement is really like the red line that you can see through all of these patients. Increased likelihood of unemployment, increased absence due to sickness at work, risk of criminal convictions, like I've said, traffic violations, and a low self-esteem, which is really almost at the core of the rest of the pathology that we see. So once again, we see addiction, mood disorders, generalized anxiety disorder, Post-traumatic stress disorder. These patients have a higher risk of experiencing traumatic things because of the high risk-taking as well, and of course the personality disorders. So, having said all of that, how do we piece all of this together? Ooh, this slide is really bad on a big screen. We kind of follow, at the center of our work, we follow this approach. So it starts with awareness, and all of you are aware of it now, so you can all start. The next thing is screening, then we go on to diagnosis, and we look at the big picture. It's just a bit of a structure for where we're going with this. So because of the awareness and the high numbers, the advice is really to screen all patients in addiction units. And I put 3 examples up here for you guys to use. We use the first one. We don't use the Connors, but we use the ASRS from the WHO. And it really is quite an easy questionnaire. You can fit it on one page. Everybody gets it in their admission packs. They screen, they fill it in. It's a self-reporting list. And the counselor can look at it and refer through to the psychologist or the psychiatrist if necessary. The important thing to remember with this is that screening tools are not diagnostic tools. A lot of people think that if you fill in a Connors rating scale and you see it's positive, then good stuff, we have the diagnosis. It's not true. Screening tools are only for screening. I'll show you a very nice diagnostic tool just now. But they are very, very easy. It really takes 5 minutes to fill in. So how do we go about the diagnostic process? The first thing that I really want to focus on is to do a biography. We've just looked at the lifespan of Fidgety Philip and Johnny Hayden Eyre, how they became adolescents, how they are now adults. Really start at the beginning. And I even start at were you a wanted pregnancy? I think that's also what Christoph referred to as the whole lifespan is so important. It's not just in one moment in time. Look at the ACEs. Childhood trauma. Look at the impairments and the consequences. In the screening list that we use, we have a lot of, there's a whole list of examples of places in your life where you might struggle. Very, very important to look at those. Do a full psych evaluation. I often see people in addiction care units only focusing on the addiction, or vice versa. That's the next one, I think. Yeah, full addiction evaluation. So you have to do both. And in the addiction evaluation, I don't know how it is here, but where I was trained, we were really not well trained in addiction care. I learned that later in life. And where I work now, the psychiatrists are still not all trained in addictionology. So do what you are trained in and refer for what you need. Family assessment, including a genogram, very important. I'm sure there's going to be a lot said about this afternoon with ARISE. So the diagnostic tool we use is called the DIVA. Patients also always find this quite funny. It does translate well into Dutch. It's called the Diagnostic Interview for Adults with ADHD. So the V is volwassenen, that's the Dutch word for adults. But anyway, this thing is available in many different languages. I think something like 80 different languages. You can download it for free. This is still a picture of the DIVA 2.0. That was for the DSM 4, but now this is DIVA 5. So if you download, just make sure you download the 5 version. And what's great about this is the 15-page questionnaire. You do it with the patient, and really what they've done is they have taken the criteria of ADHD in the DSM, turned it around into a first-person language, which is great, and then they gave examples. So like here you can see examples of careless mistakes, would also be to work slowly or make mistakes. And then what we typically do is we sit with the patient when they fill this in, and it really becomes part of the therapeutic acceptance process when they see, oh my goodness, I have this. Oh yes, I have this. They sometimes get quite excited, or they can say, no, this I absolutely don't have. And then you have examples. What's also great about this is a lot of the time you don't get the collateral history from the childhood, but people can remember a lot about their childhood. And you can start off by filling this in and then do the collateral with the family to see how it was in childhood. So it really is quite an elaborate tool. It goes through all the criteria, then it has like a scoring list where you count how many symptoms there are. After that, you have a list similarly done like this with the impairment areas, with examples. So really a great tool. And this can be done as a diagnostic tool for ADHD, but next to this, you still need your psych evaluation for the rest of the comorbidities. Oh, by the way, there's also an app of this if you want. I don't work for them, but I just think it's great. Then, to piece all of this together, to the big picture, I tend to use this formulation. It's the psychodynamic formulation. So we start off with problems, but because we also work from the strengths model, we don't only like problems, we also want to see goals. So if a patient has the problem of addiction, you might formulate a goal of, I want to be in recovery from addiction. So just very simple, very basic goals. Start with formulating that. Also, I do this with the patient, because then we all both on track with where we're going with this. Look at the predisposing factors and the vulnerabilities from childhood, all the ACEs, all the stuff that made you vulnerable to start off with. The next P, it's the 5 P, so it's problems, predisposing, precipitating factors. So what triggered the most recent episode? And this might seem obvious, but this is very important because the biggest problem for the patient needs to be addressed first. If you don't do that, then you kind of lose the battle, because this problem and goals list is quite extensive sometimes. Perpetuating factors, so things that works against recovery, so what keeps this thing from going on and not being able to stay in recovery from either the addiction or the ADHD. And of course, my favorite one is the protective factors, the strengths and the resilience factors. Very important. If you work from the strengths, like the final slide of Christoph also suggested, that's where you start reframing the story. And I'm sure Judith is going to talk about strengths a lot as well. I hope so. The biopsychosocial format. This is just an example of ideas. We're not going to go through them. But sometimes it's helpful to also just sit with your patient and write them down, for them to have it on one piece of paper to say, like, oh, I have this and this, oh, but I also have this and that, and then you don't forget things. Like I said, I don't know how it is here, but a lot of centers where we consult, they kind of get stuck in the biological and think that by prescribing a medication, we're going to get there. So that brings me to medication. Let's see if I'm good for time. So treatment, we'll look at the biopsychosocial, a little bit about cultural spiritual. We're not going into that too much. We'll look at treatment models. Don't worry if you don't understand all of this just now. And how we can piece this together. So I hope I have enough time to share a treatment model with you of how you piece everything together in a treatment model. So quickly the medication. It really is quite simple. The options you get stimulants and you get non-stimulants. So the stimulant medication is the ones we know really well through all the horrible stories mostly, but methylphenidate, dexamphetamine and lisdexamphetamine, which is just a long-acting amphetamine. You get non-stimulants, atomoxetine and guanfacine. The guanfacine we don't get in Europe, but you guys get it here. And then antidepressants, bupropion. And venlafaxine is advised if you have a comorbidity of depression. So this is just kind of an overview. If you put this in another slide, the important thing here, and because that's a question we always get, is are they addictive? If you look on this side, where am I here? The stimulants work on your noradrenaline and dopamine. The non-stimulants only work on noradrenaline, and that's really the core of it. So the main neurochemical with addiction is dopamine, so you can guess with the stimulants you do get, that sounds a bit weird, sorry. Is it okay? It's okay, okay. So with the stimulants, you work with the dopamine, and with the short-acting stimulants, you get an impulse of the dopamine, and you get kind of peaks throughout the day. We don't really use them in Europe anymore. We try to go for the long-acting stimulants because then you get a plateau through the day. You don't get the dips, which are very irritating to experience the whole day. Dexamphetamine is used, not by me, but is used in Europe as well, and atomoxetine is used quite a lot. So not to go into this, but just to show you that they are, with regards to efficacy, they are equally effective against ADHD in adults. The disadvantages, important one is at the end here, abuse potential of the stimulants. That is true. Disadvantages here is a slow onset of the effect. So what's important is if you have a patient with ADHD and addiction, they want it to be treated yesterday already. So if you come with a pill like atomoxetine, you say you have to wait 6 weeks for it to work, you have a problem. So what we tend to do, and this is also quite common, is if we have a patient like that, some people are okay to wait for the effects, but sometimes we admit for typically 6 weeks to 7 weeks, which I understood from Cape Cod is quite long. So we have time for this. So we usually start with a combination of the two. So start with the stimulants so they get the immediate effect so they can follow through on therapy. And then by the time they go home, we can stop that and just continue with the atomoxetine. So the first 6 weeks, patients might have a little bit of polypharmacy. So the misuse potential, like I just explained, for non-stimulants, no. For stimulants, yes. It is important, though, to discuss the risk-benefit ratio with your patients. Very important to discuss that. This is a common question I get, and I think that's a very important one. Is does treating children with stimulants cause addiction? It's been in the media a lot, anyway, in the Netherlands, I think here as well. And the problem with the science behind this is you get two directions of thought here. You get studies suggesting that there is a higher risk of addiction later in life if you treat with stimulants. Unfortunately, these are 4 studies that indicate this, and there's a lot of critique on the methodology with them. There are 11 studies suggesting that it lowers the risk of addiction later in life. And I think the most important thing when we think about this is the only fact that we really know is that untreated ADHD is linked with an increase of addiction later in life. So that, I think, is more important than stimulant, non-stimulant. I think we have choices now. So if you think of the timeline, we don't have to treat with the stimulants anymore. And I'll show you just something. I think the next slide. No, 2 slides. There are even non-pharmacological biological treatments coming up, which are really exciting. So the treatment advice would be long-acting preparations are preferred in general because of the spikes. Discuss the abuse potential with your clients, very, very important. Short-term prescriptions, example, weekly. If you think that somebody might abuse it or sell it, you can ask the pharmacy to do that. Have a clear treatment plan, which you evaluate frequently as well. And you can take medication under supervision only if absolutely necessary. And the reason I say this is in addiction, part of addiction is attachment and trust. And if you work with that trust with the patient, it works much better than the distrust of we are going to control every single pill that goes into your mouth. But like I said, this is very individualized, and you really have to discuss it with the patient, and it also comes out of the evaluation. So first-line treatment for adults with ADHD is still, this is the European guidelines, is still stimulants, the long-acting ones, preferably. In adults with ADHD and addiction, the guideline is to use atomoxetine, the long-acting one, or bupropion. I'm not sure if the trade names here is not important. Titrate and monitor the side effects. Continue as long as clinically useful. So what we typically do is we take drug holidays, and these medication holidays are not the ones that we used to from 20 years ago, where you didn't treat the child during the holidays or in the afternoons. No, you have to treat the child always, or the adult as well always, and then once or twice a year you can discuss with the adult whether you want to, it's a good opportune moment to stop the treatment for a week or 2 and see how it's going without the medication. We know that our brains develop a little bit later now. At the time I was in medical school, we thought the prefrontal cortex only continued developing and myelinating until we were 18. Now we know it's up to 40. So we know that there is always a chance of it improving over time. Co-administration of medicines is relatively common. That's what I just explained about the atomoxetine and the methylphenidate together. Then a new treatment. This is actually FDA approved for you guys, not for us yet. Trigeminal nerve stimulation. It's quite great. You get a little box this size with a sticker on your forehead. You go to bed with it. You wake up, you take it off. It's 8 hours during the evenings that you sleep with it. And it stimulates the prefrontal cortex. And this has been studied. There's only one randomized controlled trial that was published in April this year, and that was found equally effective to atomoxetine. So this is the beginning of something that I think is very exciting. So, treatment is not just about fixing what is broken, it's also nurturing what is best in us. I love this statement. It's from Martin Seligman, the founder of positive psychology. So let's look beyond the medicine. So this is a psychosocial model that was developed in the Netherlands of what you can do with patients besides the treatment. Coaching, CBT, psychoeducation, look at a mix between exercise and diet. I was happy to hear this morning that you guys are also excited about looking at exercise and diet and other things than just the pharmacology. What I should actually add here to coaching is mindfulness and meditation. I have a lot of patients that get a lot of benefit from mindfulness and meditation, yoga as well. And I even had a few patients that stopped their medication that's able to function just with yoga, morning meditations, and mindfulness exercises. So I think we need to do a little bit more research there. So coaching topics that we typically use, acceptance of the disorder. I once had a patient he was 47 years old, and he came to me one day. Well, I was called to the unit and I had to come to this emergency. He's crying, he's suicidal, and I get there and I was like, what's going on? And he's like, look at me. And I was like, what am I seeing? And he was like, I'm dressed like a teenager. And it was true. He was a 47-year-old, dressed like a teenager. And what had happened was the ADHD medication had worked, and he could focus, and he had his attention there. And he realized suddenly that he had early onset addiction. He was never treated in ADHD for his life. And he had what we call emotional stunting, actually, for 30 years of being not treated. And that really pushed him to the suicidal thoughts. So we did counseling on him, and it turned out fine. But acceptance of the disorder is really, very important and could be quite difficult. Some patients are very happy, like, finally I know. But some do have to accept. Learning to deal with time management, very important. Learning to limit daily activities, like go a bit slow on the enthusiasm, one goal at a time. Organizing home, administration and finances, dealing with relationship and work difficulties, learning to initiate and complete tasks, understanding emotional responses associated with ADHD, the impulsivity, the mood swings, the irritability that they sometimes have, just understanding a lot. This is also a great slide just to show you that if you work with preschool children or young children, to also include the parents, and they have parent trainings, and later you move more towards cognitive behavior therapy, coaching, and even DBT, dialectical behavior therapy. Psychoeducation, like I say, we're quite lucky because we have the luxury of admitting our patients for 6 weeks, 6 to 7 weeks. So we really have a 4-week program of an ADHD group, and I'll show you how we fit this into a whole program just now. What we also tend to do is we do expert opinions for the families, but also for the patients. For the patients, we have once in the 4 weeks they get to speak to the doctor in a group setting, just to discuss physical things and things more specialists in that. We have brochures. Very important to have brochures for your patients. If you have ADHD, you struggle to concentrate, even in the beginning with medication, so you're probably not going to get everything from the group, and then it's nice to have a brochure that you can read later on. Be culturally sensitive. You can go mainly structured evidence-based or maybe group didactic. We kind of tend to play it by ear. We have 2 modules that are very structured and 2 which are not, because we also want to allow for people to just share the experience of having ADHD and addiction and what that means for them. So that sharing is also working on the connection, and connectedness is very important as well in recovery. So as you could have guessed, you do not do this alone. You can, but it's very difficult, so it's always important to work in a team. And in healthcare teams, we used to have the see here. So the POC, that's a term from ARISE, so you'll probably hear about it this afternoon, but the person of concern in the middle, which is the focus of the attention, coming in with the partner. And then we have the usual suspects in the mental health care team, all around here. That's a usual basic mental health care team. To get more of the social aspect and the family involved in this, you could use other healthcare professionals, and I just put a few in here which we sometimes forget. But we, for example, work with the pharmacists as well, who monitor the medication and can do drug levels. We work with the dentists. We work with sponsors, with art therapists, self-help coaches, interventionists. There's a whole range of other healthcare professionals which in the Netherlands, in any case, we tend to forget and just focus on the big ones. So we include them. So the next level of support for these patients would be the family. So think of the son, the sister-in-law, the uncle, the brother, the niece. Judith did very interesting research that shows that it takes 5 of us to replace one of the family members when supporting somebody. So not getting the family in just from a pure financial aspect, it just doesn't make sense to not do that. So then you get patients that say that I don't have anybody, I don't have any family, I don't want anybody there. Then we're like, that's okay, because you probably have friends or colleagues or a baker on the corner that you know, or a teacher or somebody else that you know. We're going to use them. So this is called the extended natural support system. Then in addiction care, we also work with community groups, community projects, spiritual guides, religious leaders, anybody from the culture. And this is kind of a map that was developed by Judith, who you will hear this afternoon. This is called the transitional field map. And this is just a way in which you can formalize your thinking about who to involve in the treatment. And then what happens is, if you just focus on the middle here, is that the family opens up and the person of concern moves back into the family. And this is what you want. What most people with addiction and with ADHD, what they struggle with in the family is that all the focus is on them. They're the black sheep of the family, the naughty one that gets pointed at. So the focus is on them, and they don't deserve to be in the middle of all of this. They need to be in the family where they belong, and that opens up the space for other things to be treated. So once this happens, you can treat other things like the depression, the anxiety, family issues. I'm going to stop talking about this because I think Judith might talk about this. Are you talking about it? I can go on with this. Okay. So, great. We're on time and we can go through the treatment model. So how did we piece... Oh, no, first, before we go to that. So there are different treatment models. I tried to order them here from the least effective to the most effective. They all work, but the outcomes are better in certain ones. So if you look at who to treat... treating only the individual gives the worst outcome. If you can treat the partner as well, that gives a slightly better outcome. Family gives the best. So the individual plus the family, that gives you the best outcome. Individual or group, individual only has been found equally effective to group only, but what is superior is group and individual combined. So if you can get that together, you get to combine group therapy with individual therapy, that gives you the best outcome. Is everybody familiar with the difference between sequential, parallel, and integrated care? So, what do we mean with sequential? Sequential means that you treat one disease after the other. So you usually would start, and this was taught when I was still in medical school, you would start with a detox, which was seen as addiction treatment, which is not. But then you should treat the addiction, and then the ADHD, and then you get to the depression. And the problem with this model is by the time you get to the depression, to the ADHD, somebody's going to have a relapse of the addiction because the mood disorder is not yet treated. So that's the problem with this model. So the next level of that would be parallel care, that you get different professionals from different teams to treat everything at the same time, but there are different teams. And this has better outcome already. But the gold standard really is integrated treatment. And in Europe, we still refer to IDDT, Integrated Dual Disorder Treatment. I think the name should change soon, seeing that we're not talking about dual disorders anymore. But there you have all the professionals treating all of this also in the same team. So the communication is easier. the expertise is shared better, there's a shared vision, and this really gives the best outcome. So if you have to design something, this is what you want to end up with. So an example of how we do it in the treatment center where I work, this is kind of how we put all of these pieces together. After initial intake and assessment and all of that, we have an initial detox phase. The detox phase can be at home or in the clinic. We have a detox facility close to our residential facility. And that's, I mean, it could be 1 week, it could be 2 weeks, it depends on the addictions. But usually patients get in within about 5 days. Then when you get there, we start with the treatment phase of the addiction, which is according to our model, which is a 12-step facilitation model. So we combine everything from cognitive behavior therapy, a very holistic approach to addiction. So we start treating the addiction and we give you the screening list, the ASRS screening list that I showed you. We give that to the patients. Patients fill that in. End of the second week or the first week in the clinic, we get it back. You get to see the psychologist or the doctor, and you do the DVAT assessment, the big psych assessment, all gets done in that week. And it's a cognitive decision to wait until then, because the first week in rehab is quite difficult. So we also give people the time to first settle. Then we do the assessments, we start the medication if needed, and you get to join the ADHD group, in which we have that whole 4-session thing worked out, and you kind of get to know the other patients in the clinic with the same diagnosis. What's also nice is people get into treatment at all different times. So if you are in week 1, there are also guys that are in week 4, and you kind of get that peer big brother support to help each other through this. So you also get a little bit of self-education amongst each other. In the weeks after that, we look at the other comorbidities, so anxiety, depression, sleep disorders. With both addiction and ADHD, you can get sleep disorders, whatever there is. Once again, as I've said, very, very important in this is treat the most pressing issue first. So very important that why are you in my office now question. If you have to sequence within the integrated treatment, work at what is most important for the patient at that stage. And through all of this, we try to involve the family. And after lunch, you're going to hear all about ARISE. We use that as a methodology to involve the families in all of this. And that really, well, gives us quite a satisfactory outcome. So my last slide is next Tuesday, which is actually tomorrow. So as of from tomorrow, what can you do? The most important point is common things occur commonly. So be aware of it. If you are working with either substance use patients or other addictions or whatever, be aware of this co-occurring disorder. Screen and diagnose cautiously. We really need to be cautious with not misdiagnosing. People really suffer when we misdiagnose, and we see a lot of cases that have to be completely reassessed. It can be very tricky to do. So refer if necessary. Integrated treatment for ADHD and addiction is more than just medication. And I think I'm preaching to the choir here, but there's a lot more to do with people with ADHD and addiction than just prescribing medication or just rehab. And we always say that one-on-one, the addiction always wins. So always think of involving family, significant others, and the whole system. And that was my last slide. So thank you very much for your attention and your time. It's been great being here. Thank you very much. I don't know how we are for time, if we need... Are there any questions? We might allow 2 or 3 questions, depending. One at the back there. Do you need a microphone?
Can you talk a little bit more? I don't really understand. I work with a lot of clients who have, a lot of adverse childhood experiences and a lot of childhood trauma and all first talk, and a lot of them have ADHD diagnoses. And I know you were talking a little bit about that. Is it like there are people that just have it, and then there are people who have it because of childhood trauma, and does that affect how people are treated? Can you just talk a little bit about the relationship between childhood trauma and ADHD?
Sure. So I think the important thing there is that having ADHD, so I mean, in that whole 4 options of what came first, the addiction or the ADHD, in ADHD is quite easy. The ADHD is always there from the beginning because it's a neurodevelopmental disorder, it's always there from the beginning, so that we know. What follows on that is puts you at risk for trauma. So you're, in general, for all those ACE criteria, you have a higher risk of having childhood trauma. So it doesn't mean that you will have them, it's just a risk factor. So some people, like you said, some have it, some don't have it. There's no real way in telling. The only way in which you can know is to really do the assessment properly and go into that lifespan, the biography, go into the genogram, look what happened in the family. Genogram, I think I focused a little bit more on ADHD now, but genograms are also about looking back in the past about stories. And now I'm treading on Judith's ground, but really look back in the history of the family and the other traumas, the intergenerational traumas and things. So there's a lot around trauma with this. Christopher and I always talk about addiction, and we say, well, it's actually a mix between trauma and attachment, the problem with addiction. And in ADHD, you get a bit of both throughout the childhood phase. There's no real way of predicting what people will have. There is a risk that the more childhood ACE criteria you have, the more complex the ADHD will be to treat. So there is a link. We're not saying we don't have a causative relationship yet, but the higher your ACE scores, the higher the number of criteria you will meet for ADHD as well. So you will probably have more severe ADHD with more severe childhood trauma, and probably more severe early onset addiction as well. So there is definitely a link between those things. So and it's very difficult to diagnose, because especially if you work in child and adolescent services, it's really difficult to figure out with a child who will probably not tell you the story in the beginning, what is going on, and there's also a lot of secrets going on. So that makes the diagnosis, certainly in child and adolescent facilities, quite difficult. So I don't know if that's an answer to your question.
Yeah, I guess I just don't really understand when is it trauma symptoms and when is it ADHD.
Should I go back to this? I have a slide, so just go back to this one. Sorry, this has all been... Where was it? Sorry, I could have just maybe done it in a different way. There we go. So this is kind of a model. I mean, it's not 100% yet, but if you look at trauma, you see really different symptoms. It's like if you look in the blue circle, those are kind of more trauma-related symptoms, if you have to look at symptoms. I mean, the trick to this is really the biography and to get the big picture. There's no quick way of just assessing this. But in trauma, you get more disassociation, being hyper-alert, the fight or flight things, the recklessness, the aggression. The irritability is there under trauma, but you can get that under ADHD as well. So it's important to look at the cluster of symptoms more than just one or two things. And that's the problem with screening lists as well. If you do screening lists, you just look at key features, if you want, and not at the big picture. Whereas ADHD is really more the combination of the inattention, the hyperactivity, and the impulsivity. So it is really, it is distinguishable from each other. But it does take a lot of work and a lot of time to get there. So, where I work, we have a small little treatment facility, but we're also part of a bigger group. The Parnassia group is the biggest mental health provider in Europe. And we have a specialized service just for children with ADHD. And they are fully booked. They have waiting lists for up to 9 months to get in. So there's a lot of work to be done. So I hope that clarifies it. Is that okay? Christoph.
Yeah, Costa, would you say that we have diagnosed false positive in ADHD instead of diagnosing trauma too many times, putting the blame on the kid, on the responsibility of the kid, rather than looking at the family system as dynamic, and that has led to aggravated problems? Is that
Yes.
something? So yes?
Yeah.
How much?
I think, how much, should we study that? Yeah. Well, I think, you know, if you look at that timeline, you can really see that it was a bit fuzzy, the diagnostic criteria. I mean, we spoke about behavioral disorders in children, which was really like anything that was difficult in parenting, really. And there you start with the blaming and the shaming. It's a difficult child. That's kind of where we start. And that's not that long ago. I mean, it was 1960s, we still had those kind of practitioners, well, with those kind of thoughts, really. And nowadays we get closer to what it really is, what the diagnosis it really is, how to do it. Everything becomes a little bit more refined in that. And the problem is, you touched on it, but trauma is, for example, here you guys are much more aware of trauma. Europe is really lacking in that aspect, right? I mean, the UK, I think it's the same as the Netherlands. The Netherlands is also lacking in family involvement, for example. So the blame culture is quite big, you know. It's even in addiction, I think, loose from the ADHD, just being diagnosed with an addictive disorder, already you get like blame, and then on top of that you get the blame for being a naughty, impossible, absent-minded person. So I think there's a lot of misdiagnosis. We should do a study to get numbers behind that. That's exactly.
It also goes the other way, where the parents are blamed and... Sorry. I think people can hear me.
Can everybody hear Judith?
No.
Let's see. Not sure if we're supposed to do this.
It may or it may not.
You think we get that going?
Okay. No.
No. Do you want mine?
No. You'll just repeat my question. It's okay. I'll just repeat it.
There's another one here.
Yeah.
It's fine, I'll give you this one.
It's fine. You'll repeat you can repeat my question, or I can say it here. I agree with Christoph, but I think the other component is that depending on which door people come in, if the child's admitted to child psychiatry, there's as good a chance that bad parenting will be blamed rather than bad kids. And it really depends on where they're treated. If they're treated in an addiction program, then they're the bad people. And I think we really have to stop the blaming, because as long as we're looking for blame and pathology rather than looking for what do we need to do to get healthy, we're going to run into this issue. And back in the 60s and 70s, regardless of what happened, the parents were always blamed, to the extent that there was an intervention called parentectomy, because the staff would heal the kid, and then the kid would go home and relapse or behave badly, as they do with ADHD, and it meant that the parents were destroying what the staff had done, and then it would be back to treatment. So I think we're getting past that cyclical treatment, but we're still looking for villains instead of looking for health and healing.
Yeah. Absolutely. One more question.
What's the impact of the social and cultural new norms through time and change? Just culturally things change. Mixed cultures influence behavior, where you could misdiagnose a change in cultural behavior as being a disease or a symptom of something, so that you wind up misdiagnosing. In fact, cultural and integration of cultures has had an impact on these diseases.
Yeah, absolutely. So what we see in, read it out. So what we see in the Netherlands, for example, we have, I mean, in terms of diversity, we have Moroccan and Turkish subcultures within the Dutch culture, which are really not yet well integrated. And there's, for example, a lot of shame within the family. So you get the double shame again for ADHD and addiction. Also, the services, like Judith said, are aimed at treating Dutch people in the Netherlands. And if you come from a different cultural background, already the the counselors are often not well trained, working with different cultures. So you also have kind of, we say in Dutch, you have the glasses and you look through the lenses of your own culture at other people. So intercultural psychiatry is really so important in this. And I think with everything in psychiatry, it's not only in behavioral or childhood psychiatry. I think it's with everything, you know, like we misunderstand each other when we talk about depression or anxiety or trauma. And so it's on the one hand, it's the misunderstanding in the diagnostic phase, but it's also the lack of knowledge of where people come from and what they've lived through. And I think this is not, you know, sometimes we just think that's between continents we don't understand each other, but it's actually in communities itself, like you said, that we often misunderstand each other. And that's actually just a matter of being interested and listening. That's where you start healing that. And having conversations, you know, like getting the community involved in things, opening up the discussions. I mean, that's something with the self-help, with the fellowships, you call it here, we call it the self-help groups. Part of the magic that happens there is the cross-pollination of ideas and background stories. That's kind of part of the magic that happens there, and that's what we try to replicate in the ADHD groups, for people to also to just hear from each other, like, what did you have as a child? Oh, how was your mother, you know? And then you also, because we admit people from all cultures, you get that cross-pollination already. But I think really the future of psychiatry is in the corner of intercultural psychiatry. There's a lot of work to do there. And our diagnostic systems kind of fall short because it's not multicultural. You know, they tend to cut out things that are multicultural from time to time. So I'm going to try and keep us on time. So I think we're good for... is there one more question? We're good? Yes.
Has there been any research done on the working with executive functioning and teaching kids about executive functioning and the families, the parents, as far as its impact on ADHD? Can you retrain the brain that way?
Judith, you want to take this one? Okay, so the question was if there's a research done on executive functioning and retraining the brain. I think that's where the therapy comes in. You know, you can always retrain the brain. It's got to do with neuroplasticity that we continuously learning about now. So I think that's the therapeutic side of it. So yeah, the short answer is yes. Whether that's enough to kind of contain the person enough to be, you know, regain functioning, that's the question, you know. And that's also with the medication. What we see in antidepressant medication, for example, through neuroplasticity, you do recover the receptors, the receptor density. So the brain recovers from depression quite often by treating for 6 months. And you see that in therapy as well. So yeah, I think a lot of schooling programs are needed as well. That's what I understood from Cape Cod as well, to help with this. Do you want to add something?
One of the things that we see with mild traumatic brain injury, and brain injury is doing neurobiofeedback and helping people control their brain waves and become more able to relax and slow things down. I think that, and we are seeing with the trigeminal nerve intervention, there's an awareness with the neuroplasticity that we can make some very major changes, but it's extremely slow. There was one case where a man was in a tractor-trailer accident and lost half his brain. And after cognitive therapy of, I think it was about 6 years, the hemisphere remaining had learned some of the skills needed that normally are in the other hemisphere. So I think we're really in our infancy of knowing how much we can do. So it's a great question. We know with traumatic brain injury, with very intense cognitive therapy, we can regain things. So I really believe that we will be able to change patterning over time. but we're nowhere near there yet. Thank you.
Great. Well, thank you very much, everybody. I think